All right, welcome everyone. I'm Dan Limmer from Limmer Education. We're here for another Jeopardy! Tonight's topic is pathophysiology. I'm excited to have you all here, and we're going to get started in a second. Just a couple things we're going to talk about in the beginning. This is fun, and it's also based on pathophysiology. Pathophysiology is just so important for everything that we do, understanding really at all levels of EMS. So we're going to go through our Jeopardy! Categories. And I think that they will challenge you a little bit, that you'll learn a lot as you do this. Hello, Lauren. And we're going to get started here. So I guess what we'll do, probably the first thing I should do is for those of you, some of you already said hi, which I appreciate. I'll introduce myself really quickly here. My name is Dan Limmer from Limmer Education, and I've been involved in EMS for more than 40 years. I'm the Chief Knowledge Officer here at Limmer Education. I'm a paramedic, police officer, educator, conference speaker, written a few textbooks in my time, including the Yellow Emergency Care textbook, which is something that I'm very proud of. You can even see it on my shelf back there. And we're going to do Jeopardy! So, without any further ado, I'm going to switch to my Jeopardy! Screen. Now, what we do here, there's a little bit of a delay. We have to get used to that. But you can call out which thing that you want to do here on Jeopardy! And we will put it up on the screen. I'm looking at the chat right here, and we're gonna do it. So I'm getting set up here. All right, I'm gonna pick the first one just to go through, and so we've started it and done something here. All right. All right, we'll start with ventilation and respiration for 100. Type the answers in the chat. I'll know what you're doing. This is the amount of dead air space in the average adult lung. Hello, everybody. Lots of highs there. Hello. This is the amount of dead air space in the average adult. Answers in the chat section. Got a lot of 50s in the comments there. One of them is correct. There's a couple other ones that are coming through. Now, we'll do all of these Jeopardy! Choices here. And then I've got a couple sample questions I want to put up for you. Some of the new National Registry-style multiple response questions. All right, people are looking at that. Let's take a look and see what the correct response is here. I want to keep this moving along a little bit. The correct answer, which many of you had here, is 150 mLs. Now, this is going to come up again, just so you know, as we go through and we do this. All right, so do we have a request for something else over here? Anything else we want to do? Do we want to try? All right, I'm going to go to trauma. I'm going to go mid-level trauma, because who doesn't like a good trauma as we go here, right? I'm going to put this up on the screen. Oh my goodness. We got a little bit deeper here. Going for trauma. Tension pneumothorax reduces this cardiac parameter to cause shock. Anybody that saw the TikToks or the other videos we put out had this as part of it. It's exactly what I did. So you pick trauma for 300, and there we are. You know, it's funny, one of the things people are saying is really part of the second part. We certainly reduce cardiac output. I guess I want to know why we reduce cardiac output. There we go. We're getting a lot of people getting that correct answer here. There we go. You know, this is an important concept. A lot of the things that I'm doing here, I think it's really important that you know. I'm doing a lot of terminology here. One of the things that you need for the National Registry is terminology. Nobody ever went to the National Registry and said, hey, I knew all those words, and that's why we're doing this. So let's look at the answer. We've got this here. We're going to talk about cardiac output in a little bit. But the correct answer here is, in fact, preload. Tension pneumothorax, if you saw my video, basically says, oh, it's a collapsed lung. It's a really horrible problem with breathing. You can lose one lung. Let's say you have a pneumonectomy, you have one of your lungs taken out. You might not run marathons, but you can still live. The real issue is that pressure takes our low pressure vessels like the inferior vena cava, and it kinks that off and reduces preload dramatically. All right, so there, I went, what is preload? There's some Jeopardy-style in there as well. Preload is the amount of blood that returns to the heart to start the cardiac cycle. Sometimes it's referred to as the amount of blood that gets to the left ventricle. And that's the preload. And because we kink that vessel, we're not getting that. All right. So I'm going to take a look here. You guys can feel free to put some of these in. I'm kind of jumping around here a little bit. Let's go over to the tough stuff, shall we? All right. Formation of this in the leg is responsible for a patient having a pulmonary embolism. Formation of this in the leg is responsible for a patient having a pulmonary embolism. All right. Yeah, I actually had one of these, believe it or not. It was after surgery. They gave me TXA, and that caused a clot in my leg. And we're getting some great answers here. Yeah, I'm just going to put it up here so we can move along a little bit, because we have a lot to talk about. The correct answer is a deep vein thrombosis, or a DVT. How does this fit into pathophysiology? If you have somebody with a sudden onset of significant difficulty breathing, you might want to ask them if they've been in a cast, if they've been immobilized at all, if they've had any things like that. Now, there's two types of a pulmonary embolism. They're classified as massive, which you basically drop dead from. It's believed that a lot of people that go and then drop dead actually have a PE rather than an MI. Then there's submassive, which is one you live with, but is still quite serious. And that is a DVT, and it's a question that I want you to ask in patients with that deep vein thrombosis. All right, I'm going to go through. I'm going into the middle now. Let's go to, I'm going to go, and just feel free to type in what you want me to pick. I'm just going to bounce around here a little bit. Autonomic nervous system for 400. We're going into the challenging part here. Ooh. This cranial nerve is a primary messenger for the parasympathetic nervous system. This cranial nerve is a primary messenger for the parasympathetic nervous system. All right, Javier, we're going to get that one next. Lawrence and Terrence. Yeah. Crown even got the number of the nerve. I'll go for a little bit more, let a few people respond. I guess once we start seeing them roll through, people can say, oh, look at this. But this is important. Remember that the parasympathetic nervous system slows. Sometimes it's called the rest and digest nervous system. And this is what happens if you're sitting on the toilet and you're, this is going to be gross, you're trying to squeeze out a big one, right? And you're pushing really hard. Well, the body interprets that as extra pressure. And then that sends a message to the brain. The brain says, okay, I'm going to slow things down a little bit. How does that happen? Really through the vagus nerve. Also, when somebody vagals out or has vasovagal syncope, our vagus nerve, the 10th cranial nerve, is the one that is responsible for that. Great job on those. I had a request for trauma for 200. And I can do that. Here we go. I want to make sure that we give people time to do this. Yeah, the vagus nerve. All right, here's the new one. Abdominal pain that is often diffuse and difficult to pinpoint. What type of pain is that? Abdominal pain. It's diffuse and difficult to pinpoint. That's known as what? Couple different types of abdominal pain. Look at you all go. I'll tell you how my students taught me to remember this. You know, educators learn from their students as well. Because, wow, look at you all. Give everybody a chance to answer here before we go. But we went from the vagus nerve to another V word, as we see here. Lauren, you went over this today in class? I knew that. I'm kidding. Visceral pain is the correct answer here. Now, how did my students teach me? Visceral is vague. That was the thing that my students, it's like, duh, right? The organs themselves don't have really great nerve endings. That's why your appendix starts with pain around the belly button or the umbilicus, because sending it back to the brain, that's kind of where the nerves go back to the spine. You say, gee, it's you know, my belly button. And then it's kind of funny. And then you don't feel well, and then it gets worse. And then the appendix gets big. And then it knocks on the abdominal wall. Now there we have pain, ability to really interpret pain and tell where it is. Sometimes that's called parietal pain, pain that you can pinpoint, also called somatic. Visceral pain is vague. Comes from you, often from organs in the abdomen, because they're not well innervated, right? You take and you slam your finger with a hammer, you know exactly where it hurts. Abdominal organs, not that easy. All right, I have a request for tough stuff for 500. Whew, are you ready? A little nervous here. Here we go. Oh, that's right. I got really evil with this one. I got really evil with this one. You wanted tough stuff, Miguel? We got some tough stuff here. Now, some of these things, it's okay if you don't know them, because remember, we are on tough stuff, and the more value for each one, tough stuff for 500 is probably going to be the toughest question in this deck. But there's a couple points that I want to get from this. How many milliliters of blood does the average adult female have per kilo of body weight? Now, I can give the answer relatively quickly here, because I think that in this, yeah, per kilo. You figure that the average adult male has 5 to 6 liters of blood. Females, a little bit less. All right, now, I'm not sure how many of you Googled out there, but I'm going to get to the answer here. Now we're getting pretty close in some of those answers, all right? And I don't want to spend too much time on this. The actual answer on this is about 65 milliliters per kilo of body weight. Males are a little bit higher, 70 to 75 milliliters per kilogram. Now, why is this important? Well, one, I wanted a really tough question, but I wanted you to think about it, because this is an average. And if you think about how much blood someone's lost, maybe that's another question somewhere, we have an idea of what percentage of blood that might be in a person and how much a person has. Also means that a 70 kilo person is much different than a 200 kilo person, the amount of blood that they have when they do that. So it's about 65 milliliters per kilogram of blood. Had that request for tough stuff for 500, and I think I gave that to you. Let's go back to some 100s. I think that was a tough one. I'm gonna go back to the 100s. Let's do autonomic nervous system. These receptors in the sympathetic nervous system cause vasoconstriction. What receptors in the sympathetic nervous system cause vasoconstriction? Now, if you're in an EMT class and you weren't taught this, this is pretty important stuff. You need to know this. So there's basically that we study in EMS. There's a couple different kinds. These receptors, if I were to give a medication and I wanted to cause vasoconstriction, where would that come from? What's really interesting is one of the answers that you're seeing here a lot actually is going to be in another question we get. I can't give you a hint. Nana and Reno seem to have that one. Now we're getting it. Javier, there we go. Skylar. So I'm not going to give you all of the receptors, but it is important that you know these because I'm going to cover the main ones that we need to know about one way or another. So what is the correct answer here? Correct answer is alpha 1. Alpha 1 vasoconstricts. Now, yeah, alpha 1. Now, there's alpha, and then there's another side here. Somebody had mentioned beta, but there's really more than one beta we need to pay attention to. But we're going to get to that one as we come through here. Do you want to do another one in the autonomic nervous system? I find this is something that isn't taught as much as it should be. Let's take a look at autonomic nervous system for 200. And the answer on that one again was alpha 1. Oh, look. Beta blocking medications do this to the heart rate. Now, adrenergic is technically a correct answer, but we can break it down further than that on the last one. On this one, beta blocking medications do this to the heart rate. I'll give you a little hint as we go through. This one is a 100 or 200 kind of thing, autonomic nervous system for 200. And it seems like we're getting pretty good answers here. And the beta blocking medications usually end in OLOL, atenolol or metoprolol. And as people pretty much here are saying, the correct answer is that it slows the heart rate. Now, if you've been out on calls, whether maybe you're a medic and you're out there and you've been on calls before, maybe you're an EMT, you get a call to a nursing home or somebody where you have an older patient and you feel their pulse. And their pulse feels amazing. It's going along at bump 1,000, bump 1,000, bump. So it's 56 and you're thinking, wow, and it's steady and it's strong. And you're thinking, gee, is this a bad bradycardia? Look at their med list because there's a good chance they're taking a drug like atenolol or metoprolol, and those OLLs are beta blockers that slow the heart rate. And that's good. Where in the book is the information on the nervous system covered? Well, it depends on what book you have, but I would say that should see some of that in pharmacology because we have medications that act on that. There'll be a question on that later. Possibly in the pathophysiology material as well. All right, let's move on. We've done nothing in cardiac and respiratory yet. I don't see anything in there, so I'm going to go up to 100. Let's start relatively easy with cardiac and respiratory. This rhythm will be shocked by an AED even when the patient has a pulse. This rhythm will be shocked by an AED even when the patient has a pulse. All right, got some requests here. All right, Lawrence, if I tell who got the right answer here, I guess I'm saying it. Think about this. Will VFib give you a pulse? There's only two rhythms that the AED will identify and shock. And VFib is such disorganized activity, it won't create a pulse. However, there we go. We're getting into it now. And people often say, oh, the AED won't shock somebody with a pulse. The AED doesn't check a pulse. That's your job, right? That's important to remember. So it's possible, I'll put the answer up here. You got people going. Ventricular tachycardia. Ventricular tachycardia, if you're riding with a medic, right? Maybe you are a medic. I remember one time, I could probably still show you the house years ago. Woman was weak and she was a little sweaty and didn't get out of bed. Her kids were concerned. And we put the monitor, put the leads on the monitor. I look at that monitor, it's like, oh, it was VTAC. I'm like, whoa. But she was talking to us. And, you know, that doesn't go on forever, right? But you don't put the defibrillator on because they're talking to you. Do you want to have the pads handy? Absolutely. Remember that the AED does not check a pulse. That's why we check the pulse. And if we don't have one, then we can put the AED on and analyze that, you know, for the EMTs and AEMTs in the room. That's why it's important, because the AED doesn't know between pulseless and having a pulse. And ventricular tachycardia can actually have a pulse. Now, other rhythms that you may find, right? We have asystole, which is flat line. We have pulseless electrical activity, which is where you have lots of good squiggles, but no pulse, right? That's often because maybe there's not a lot of blood in there and some other reasons like that. So that's why checking the pulse is important before using the AED. All right, I had to request for trauma for 500. All right, here we go. Speaking of blood loss and PEA, think of PEA as the heart, the electrical activity of the heart is still going, but the muscle isn't squeezing. Or maybe the muscle's squeezing, but there isn't any blood to pump around because they've exsanguinated. Loss of this amount of blood in an average adult is generally considered irreversible shock. The loss of this amount of blood in an average adult, in an EMS, we're really not average adults. Adult is the one we sometimes question. It's generally considered irreversible shock. Some things we'll talk to you about 4 stages of hemorrhage. And it's very difficult to estimate blood loss. It's actually been studied. We don't do it particularly well. You know, depending on where you are, if you have a heavy coat on, if you're laying in a carpet or a bed, sometimes the blood soaks up. It's kind of difficult to tell. But there is an end point. There is a point where we can't come back. So while that is generally stage 4, and you're correct, we go in liters, recalling that just on average, we have about 5 liters of blood. The correct answer here, I don't want to stop people who are answering, but the correct answer, irreversible shock, is generally 2,000 milliliters, 2 liters of blood. I mean, picture a 2-liter soda bottle, right? That's about 40% of blood from that average adult. And that is generally considered that stage 4 hemorrhage, and something that's considered generally irreversible. All right. I had a request for cardiac and respiratory for 200, so let's jump up to that one. Now, before I do this, how are you all doing out there? Is this working for you? Are you doing good? A little bit of pathophysiology review working for you all? Just let me know in the chat. I'm going to pop this question up here, but say hi and let me know how it's going. Cardiac and respiratory for 200. Albuterol acts primarily on this receptor in the sympathetic nervous system. Albuterol acts primarily on this receptor in the sympathetic nervous system. Oh, I'm glad you guys are enjoying it. Hi. Albuterol is a medication that I'm pretty confident that almost anybody that's attending this session about to take a National Registry exam can give. Now, this is a little easier, I think, than the alpha-1 that we had before. Medics have some drugs that will have some alpha effects. But yeah, Sarah's got another good answer there. Miguel is back. Andrew, Skylar. There we go. So in this, the reason that we want to use albuterol is because it acts primarily on the lungs. Now, it doesn't mean it can't have a little crossover into another beta realm, maybe a little bit. Also can cause some tremors. But albuterol is a beta 2 specific medication. We could give epinephrine for an asthma attack, but that's going to cause vasoconstriction and speed up the heart, which could really raise blood pressure, and that's not good. We want something that's going to work primarily on the lungs, and that's what we have with albuterol, and that's affects beta 2. All right, and that dilates bronchioles. All right, we're doing good. Let's do, we're a little shy on ventilation and respiration. Let's take a breath. Pardon the bad humor. Respiratory failure involves reduced values in one or both of these two factors. Respiratory failure, I have my radio voice on. Respiratory failure involves reduced values in one or both of these two factors. There, that was the official announcer voice for you. Oh, Scholar, you're right. That's another thing. You have beta 2. You have two lungs. And that's the way to remember that. Beta 2 works on the lungs. I like it. All right, we'll keep going in respiration, Javier. Respiratory failure involves reduced values in one or both of these two factors. I want to compliment people how to put in the right answer, but if I say that, then you'll all know. Now, one of the things we've seen here is ventilation and respiration. Let me talk about those just briefly. Ventilation is moving air in and out of the chest. Respiration is the exchange of gases. We have external respiration, which is between the alveoli and the cells in the pulmonary capillaries. Internal respiration is between the blood cell and the capillaries in the body. And every once in a while, you'll see that on the National Registry. External respiration is the gas exchange that occurs in the lungs and the alveoli. Internal respiration is between the blood cell and the cells of the body. But that was a little aside. That was a bonus we got here. Because I have to tell you, well, a long time ago, the registry found that people were doing so poorly. I'm talking 20 years ago. People were doing so poorly on the National Registry, they did a special airway module because we didn't understand respiratory failure well. It's hard to picture yourself talking to a person and they're gasping for breath and they're talking and they're kind of looking at you, just looking for help, and that we may have to ventilate that person, right? But doing that before they go unresponsive or code is really important. Those two factors are respiratory rate and respiratory depth or volume. All right, that's really important. Rate and depth. You need both of those to not be in respiratory failure, for your breathing to be adequate to support life. All right? The rate, and don't go with any set rules. You know, less than 8 intubate, or, you know, more, 12 to 20 is the normal respiratory rate. Well, it's normal for who? Here's what I tell my students. I find a healthy student sitting there and I say, listen, I said, let's say you and I leave the classroom here and there's 3 flights of stairs. We run up and down the stairs a couple of times. Assuming I come back alive, who's going to be breathing faster? And they'll all look around like they want to say, it's like, you are, not me, right? So I had a guy laying in bed, respiratory rate was 18, and he was septic. In the Q-SOFA and the SOFA scores for sepsis, rapid respiratory rates, but that's relative. If you're not exerting yourself, it's important. So respiratory rate and depth are really important. You need both of those. So the rate itself generally can be very, very low or very, very high, right? If you breathe way too fast, nothing's getting to the alveoli. But you also have to have a certain depth. Only takes one of those. Anyone's not there, you're going to be ventilating. That person is in respiratory failure. So the answer is respiratory rate and respiratory depth are both required. If even one of those is inadequate, the patient needs to be ventilated. All right, I had a request for respiratory for 300, keeping going with that. An average adult BVM can hold this volume of air. How much air? Let's say that you squeezed all the air out of that BVM. How much air would come out? Oh, I'm going to surprise you on this one. The number that most people are typing in, that's the amount of the average breath. The average breath volume is about 500 mLs. That Heart Association says, just enough to make the chest rise. That's about 500 mLs. I may have missed some, but the real Yesco has got that one. It varies a little bit from BVM to BVM. Catherine and Kevin and Skylar are back. Let's put this answer up here. 1,500 mLs. Some might creep up to 1,600, but you know what? You only need about a third of that. So those people that are holding the mask on and then crushing that bag against their leg, trying to get every last drop of air out, maybe tanking the blood pressure by messing with those into those pressures in the chest, and maybe forcing air into the stomach. Our ventilation should be slow and steady, not squeezing the bag too fast, only enough to make the chest rise, and then we stop. That's generally about 500 mLs, only a third of the average BVM. So remember that you don't want to collapse that puppy, right? Let's say you're doing it great. You got somebody holding the mask on. You got somebody else squeezing the BVM. So you're doing that 2-person technique, which is recommended because you get a good mask seal and squeeze. When you got the person squeezing the bag, squeeze, and then you're doing it once every 6 seconds, about 10 times a minute, right? And you're just going through and doing it, whether it's asynchronously through a tube or whether you're just ventilating somebody every 6 seconds, just enough to make the chest rise, only about a third of your BVM. All right, so where are we now? Let's start whittling down. I think some of the most challenging ones we've had here are the autonomic nervous system. So I'm going to go for autonomic nervous system for 300. This sympathomimetic medication is given to patients experiencing anaphylaxis. This sympathomimetic medication is given to patients experiencing anaphylaxis. Another term. One thing we don't do at Limmer Education is shy away from the tough stuff. No one's ever gone to the National Registry and said, hey, I know all those words. I'm not going to go easy on you here. Now, The answer is relatively easy, but I got to use the word sympathomimetic. That mimetic, think of that as mimicking. It mimics what the sympathetic nervous system would do. And the epinephrine here that everyone is typing in, I'm just going to go for this one because what I really wanted to do here was put a word up there and see if I could get you. See if I could get anyone to say diphenhydramine or methylprednisone or, solumedrol. But sympathomimetic means we mimic the sympathetic nervous system. Epinephrine is a beautiful sympathetic nervous system drug. It has alpha-1 properties, right? Constricts blood vessels, and that distributive shock is great. It opens up the lungs. It stops that excessive capillary permeability that makes our face swell. And it also has beta-2, which opens up the lungs. It's a beautiful drug. Do you know in the United States that about 200 people die a year from anaphylaxis? Now you might say, that's not a lot, unless it's someone you know. Those people that die generally don't get epinephrine soon enough. In class you're taught, well, it's either an allergic reaction or it's anaphylaxis. The fact is most people go in between. So when you get the person that says, I got stung by a bee and I'm allergic, but I don't seem too bad, then they start getting covered in hives and they say, I'm getting a little tickle in my throat. You should be reaching for your EpiPen, right? Because you don't want to wait till it gets bad for it to happen. No, I'm not medical control. I always follow your guidelines. But don't wait for someone to be near death to give epinephrine, right? It's an amazing drug to be able to do that, all right? So 1 to 1,000 is the concentration. That's what we give. We give epinephrine 0.3 to 0.5 milligrams intramuscularly in the lateral thigh. Now you may say to yourself, okay, Limmer, 0.3 to 0.5? The paper that came out from the allergy and anaphylaxis docs say that sometimes 0.5 is appropriate. Now your EpiPen has 0.3, and that's great. Keep another one handy in case you need to do it. But 0.5 is actually fair game according to the allergy and immunology docs. Okay, let's see what we got. I didn't see any other choices come through here, so let's get rid of this 100 up here in trauma. Should be an easy one at 100, right? The pulse does this when intracranial pressure is on the rise. The pulse does this when intracranial pressure is on the rise. What would that be? And I've got to tell you, there's a couple things that my students almost always have trouble with, and when I talk to people and teach classes, it's the same thing. Vital sign trends and left versus right heart failure. Those are tough ones. The pulse does this when intracranial pressure is on the rise. And we're getting largely correct answers here. Sophia, hers really declines. Lots of E's on the end of that one. There's a comment here. It decreases because all the blood is in the brain. Let me tell you about that. Let me give you the answer first. How's that? It slows, becomes a bradycardia. Do you know why that happens? What's interesting is about 50 to 75 mLs of blood starts to squish the brain. You can't lose enough blood into your brain to cause shock, right? So what happens is as the brain gets squished, it's harder to get blood up into the brain. But what's the body's prime directive? Feed the brain. The brain has no reserves of oxygen, has almost no reserves of glucose. The body feeds the brain at all costs. So if there's pressure in the brain, the blood pressure can go up to 220 over 130, right? Just to push blood up to the brain. But our body then says, holy cow, the blood pressure is so high. It's like the other part of the brain didn't get the message. So it wants to slow the heart rate to try and bring the blood pressure down. It's like the body's getting two different messages at the same time. So this heart rate slows because the body senses that the pressure is so high. Now, questions that I'm going to stop explaining right there, but 2 questions left in this Jeopardy. are going to further explain this. All right, let's go on. Let's start whittling these down. Let's do tough stuff for 200. The 5 Ds of large vessel occlusion stroke include dizziness, dystaxia, dysarthria, dysphagia, and one other one. What is that one? The 5 Ds of large vessel occlusion stroke, sometimes called posterior circulation stroke, include dizziness, dystaxia, dysarthria, dysphagia, and what? I want you to know I can go through and teach on every one of these things. I want to respect your time in doing this. And it's not disco. Got a couple of the right answers in there, but not a lot of them. You know, we were never really taught about posterior circulation strokes, these large vessel occlusion strokes. About 80% of strokes are ischemic. It's a blocking of a blood vessel. About 20% are hemorrhagic. Of the 80% that are ischemic, they say about 20% of those actually occur in the large vessels in the posterior part of the brain. Now, why is it important to identify these? Because those big vessels, a really comprehensive stroke center can go in and suck that clot out even up to a day after the onset of the symptoms through a thrombectomy. They go in, they pull that clot out up to a day. But we have to know this. Our FAST exam isn't enough anymore. So the correct answer here is diplopia, or double vision. Now, what's the other reason I chose to put this in here? Because we know dizziness. Diplopia is double vision. Dystaxia is uncoordinated movement. Now, how do you test that? Put your finger out in front of somebody's nose, have them touch your finger and then their nose, finger and then their nose, and then do it with both hands. That's one way to check for that, and that's not part of the FAST exam. Asking about dysphagia or difficulty swallowing, checking their coordination, and dysarthria is a problem with the motor part of speech. It's not perception or expression. It's the muscles and nerves that are involved in talking. When the tongue doesn't move or something is affected, that's called dysarthria. It's part of the mechanics of speech. So these are things I want you to add into your, you can use FAST Ed, you can use, I don't know what the other one is, but there's now different exams that involve some of these things, and I think that that's really important for you to do. All right. All right, so where are we now? Let's make sure I didn't miss any requests here in this. All right, we got people from the same school that's supporting each other. That is awesome. Sometimes that's missing in EMS. Supporting each other, the camaraderie I see in these things, I hope that it continues into the station, right? And that you get that while you're out there, especially when you're new. Let's do cardiac and respiratory for 300. What two factors combine to determine cardiac output? I told you we're going to get into some of the things that we've talked about here. Matter of fact, some of the answers that have been put in for several questions are soon going to be right. Union County College. This friendship is so cute. I agree. I agree. It doesn't cost anymore to be nice to somebody, and it feels really good when you have the opportunity to do that. And the other thing I'll say is that if you're new and you're studying for the National Registry and you found somebody that was really good to you, helped you along, helped you learn, get some experience and then do that for somebody else. It's really important. All right. What two factors combine to determine cardiac output? What two factors combine? Yeah, we've got that. Is Lori there? I saw Union County. It's good to, I can't see you, but it's good to know you're there. You guys rock. All right, what two factors combine to determine cardiac output? Heart rate and stroke volume. The heart rate is the pulse, and the stroke volume is the amount of blood that's pumped from the left ventricle with each beat. Generally, it's about 70 mLs of blood. So a heart rate of 70 and a stroke volume of 70 gives you about 4,900 mLs, almost 5 liters of blood as a normal cardiac output. But what happens if my stroke volume drops? Maybe I've got a GI bleed. I don't have the blood anymore. That's why the pulse goes up, to help maintain your cardiac output. And this is one part of the blood pressure equation. The other part of blood pressure is the amount of vascular resistance or vascular tone, the size of your blood vessels. So heart rate and stroke volume is cardiac output. Cardiac output and the size of your blood vessels help determine your blood pressure. So we're doing a lot of pathophys here. I chose doing this one, and man, it is keeping us going. All right, there's no need to be symmetrical here. Let's go to autonomic nervous system and do 500, only because I'm feeling like we should get our total nerd on now. What is the expected response of the pulse to decreased vascular tone? What is the expected response of the pulse to decreased vascular tone? Best live stream ever. I'm going to frame that one. You know, these kind of questions get you understanding. This is difficult to memorize, the answer to this one. I mean, you could, but isn't it better when you understand it? What's the expected response of the pulse to decreased vascular tone? Now let's say, getting some great answers here, we got some really smart people, and I know now from some of the schools that are here, people are taught really well, but vascular tone, simply stated, is the amount of squeeze in a blood vessel. My normal blood vessel might be like this. If I have increased tone, my blood vessels get smaller. If I have decreased tone, my blood vessels get bigger. And if they get bigger, it means I have less pressure. So what does the pulse do when our blood pressure drops? It increases our cardiac output to help counter that decreasing blood pressure, right? And that's why this pathophysiology is so important. So the correct answer here is that our pulse is going to increase because decreased vascular tone means my vessels get bigger, which means my blood pressure drops, and the pulse then compensates for that drop in pressure. Now, there's a lot of triads out there. I've seen people talk about triads. I'm looking at this now. Cushing's triad, bradycardia, hypertension, and irregular respirations, right? And that's pretty good. Now, depending on the person, you may or may not get all three of those, right? But you take a little bit of history, you got a blood pressure of 230 over 120 and a pulse of 42. It could be head trauma or maybe a spontaneous subarachnoid bleed or something, right? That's important. Beck's triad with tamponade, right? We have hypotension, we have a narrowed pulse pressure, and we have muffled heart sounds. However, that generally appears in only about 40 to 60% of people. So remember that a lot of these things we learn are in fact guidelines and not carved in stone. All right, let's get rid of this tough stuff here for 300. These measure pressure and are found in the carotid arteries and in the aorta. These measure pressure and are found in the carotid arteries, the carotid bodies really in the carotid arteries, and the aorta. And I know some of you have typed in this answer for several questions so far, and now it's your turn. There we go. Remember how I told you that when the blood pressure gets to be 230 over 120 so you can feed the brain when you have increasing pressure? It's these that actually tell the brain, hey, pressure's too high, we got to do something. That stimulates the parasympathetic nervous system, which we've covered tonight, which slows the pulse down to try and reduce our pressure. See how this all comes together? Holy cow, time's flying here. And I could teach like this for hours if you haven't figured that out. Baroreceptors. Baroreceptors are pressure receptors. Barotrauma is trauma from increased pressures, like you might get in diving or something that could happen to your ears. Baro means pressure. Pressure receptors found in the carotid artery. That's why sometimes if people have a shirt collar that's too tight, or sometimes people shave and they push a little bit too hard with a sensitive carotid sinus, they pass out because the body says, whoa, pressure's getting high, let's slow things down. Boom, they pass out. All right. All right, I'm going to go through and I'm going to pick one here. Cardiac and respiratory for 400. This cardiac arrhythmia can be responsible for a patient having a stroke. This cardiac arrhythmia can be responsible for a patient having a stroke. All right, there's so much love going on in this chat, man. All right, I'll get the trauma next. Yeah, getting some correct answers in there. Miguel put it in all caps, man. He meant it. All right, since we're going along, and I still have 3 National Registry questions I want to get through, I might go a little over the hour. I hope that you'll stick with me. And the answer here is atrial fibrillation. Why is that? Why would that cause a stroke? Well, we know that the heart normally, the atria squeeze, then the ventricles squeeze. Atria and then ventricles. In atrial fibrillation, the atria fibrillate. They just, but you know what? That's not, ventricular fibrillation will kill you. Atrial fibrillation, not so much. Why is that? Because half to 2/3 of the blood from the atria going into the ventricles fall from gravity. All right, that's okay, but you know what happens? When the atria are doing this, they're not squeezing, clots build up on the wall of the atria. And that left atria, when that blood kicks loose and goes up the aorta, goes into the left ventricle and the aorta, if it takes one of those highways off the aortic arch and goes up to the brain, it can cause a stroke. That's why if somebody says, I've had atrial fibrillation, you should say, do you take Eliquis or Xarelto or, one of those drugs for blood clots? People often are on those. So atrial fibrillation patients are often on anticoagulant medications to keep those clots from forming in the heart and preventing strokes. So, yeah, Maurice, you teach it there, man. That's good. I like it. All right, next. All right, I had trauma for 400 as a request. Ooh, let's get into some details. A pulse pressure below this level usually indicates compensated shock. A pulse pressure below this level, now I would say that's a narrowed pulse pressure, usually indicates compensated shock. Now this is actually a percentage, believe it or not, and not an actual number. It really varies depending on the person and the blood pressure. But there's a percentage of the systolic blood pressure that gives us the minimum of what the pulse pressure should be. And the pulse pressure, just so we're clear about this, is the difference between the systolic and the diastolic blood pressure. All right, systolic and diastolic, the difference between the two. 120 over 80, your pulse pressure is 40, which, by the way, is okay. It's good. Look at you. Man, we got some people doing this, getting some answers in here. I'm going to move along on these a little bit just because time is ticking away here. The answer is 25% of the systolic blood pressure. Why is this important? You could look at a blood pressure of 102 over 86 and look at that and say, gee, it's above 100, and boy, that bottom number's high. Everything looks good. The problem being is in narrowed pulse pressure, the systolic drops and the diastolic rises, and that's what makes it narrow. Systolic is the cardiac output. Diastolic is the blood vessels squeezing a little bit extra. So that 102 over 86, right, is really a pulse pressure of 16, and it should be 25. So if you see a patient, or if you see a national registry question where the top and the bottom numbers seem like they're close together, you'll get a calculator on the screen, figure it out, especially if the pulse is a little high, maybe it's 92, and they seem a little anxious, whatever, that's shock. Don't wait for them to crash before you figure it out. That's what this is about. All right, ventilation respiration for 400. This would be an easy one. Certainly is an answer. It's a little more physiology than pathophysiology. This is the point where the trachea bifurcates or splits into the main bronchi. This is the point where the trachea bifurcates into the main bronchi. There we go. Some people think that's a Toyota, the Toyota Carina. It's between the Camry and the Corolla somewhere, I'm pretty sure. All right, we got this. I don't want to stop people if you're still typing in, but I want to keep moving a little bit here. The carina is the spot where the trachea bifurcates. For our advanced people, if you go too far, that tube's going to hang a right, and that's where it's going to do it, at the carina, the spot where the trachea bifurcates. All right, tough stuff for 400. We're going to wrap up this one. Ooh, a mean arterial pressure below this number is usually considered to be shock. You got a 2008 Carina. Yeah, okay, gotcha. All right, I like the humor too. We've got camaraderie, we got humor, we got everything tonight. I like it. The National Registry is starting to include mean arterial pressure even on EMT level questions. In the 15th edition of my EMT book, I'm the lead author on the yellow EMT book, we've included mean arterial pressure in the book. More and more EMTs are using the monitors for blood pressure determination and pulse ox. And in doing that, you get a mean arterial pressure. As a matter of fact, a lot of monitors calculate mean arterial pressure, then mathematically switch it into systolic and diastolic. So the correct answer here, yeah, this is 65 millimeters of mercury is often considered shock. That's listed by the Surviving Sepsis campaign for patients who are septic, and in a lot of protocols as well. The benefit of mean arterial pressure. Now, you can write this down quickly if you want. It's systolic blood pressure plus 2 times the diastolic blood pressure, and take that number and divide it by 3. That's the mean arterial pressure. 120 over 80 is a mean arterial pressure of about 93.333333. So 65 or below is usually considered shock. And you know what? Sometimes you get that compensated shock. You get a little bit of notice. But, mean arterial pressure just kind of cuts through what's what. And it's a good number to know. All right, two more. Then I got some National Registry questions for you. Finishing up the respiratory. The abbreviation VA stands for this: respiratory volume. This abbreviation, V with a subscript A, stands for this respiratory volume. Well, I'll tell you, tidal volume is V with a subscript T. V with a subscript A. It is a word. That is, all right, I got this one more, then I'm gonna do some questions. Alveolar volume. What's alveolar volume? Alveolar volume is the minute volume, the amount of breath that comes in and out in a minute, minus the dead air space for each breath. So of the 500 mLs we generally use we bring in and out, 150 doesn't get to the alveoli. That's dead air space. We had that question earlier. So over a minute, we take our tidal volume minus the cumulative dead air space for all those breaths, and that gives us the alveolar volume. All right, and the last question, cardiac and respiratory for 500. Let's get this done. This describes how the heart stroke volume increases in response to an increase in the volume of blood returning to the heart. How the heart stroke volume increases in response to an increase in the volume of blood returning to the heart. Basically, it says, if we have more blood arriving in the left ventricle and it gives us more stretch, we have more blood for the stroke volume. Maybe we're exercising and we need that extra volume. This is a mechanism. Two people's names actually that put this together. And it's funny we do this. This is probably one of the more challenging ones. I would expect the medics here to know that. For the EMTs and AEMTs, you may not have had it in class. But the concept is interesting, right? That we stretch the left ventricle more because we put more blood in. Up to a point, it's going to recoil better and shoot out more blood. The ejection fraction, Maurice, the ejection fraction is the percentage of blood that's ejected from the heart. An ideal ejection fraction is about 70%. When we squeeze that left ventricle, about 70% of the blood gets out. If you get below 40%, you're looking at some significant heart failure. But only about 70% of the blood normally goes out. And we got it there. The Frank-Starling mechanism. And what's the Frank-Starling mechanism? You put more blood in, you get more stretch, and you get more blood that's ejected from that left ventricle. It's called the Frank-Starling mechanism. And we saved probably one of the more challenging ones for last as we do that. Now, I'm going to switch over and I'm going to show you a couple of things here. The first is that if you like this, if you like listening to me, and I hope that you do here, is at EMTreview.com. I do live weekly reviews. I go on for an hour and go over National Registry questions live. You can ask questions, do stuff. We have a lot of fun. Next one's actually noon tomorrow. So if you go to EMTreview.com, we do a live review every week where I go over National Registry questions, do a little bit of teaching all the time, and it's there. Kyler wrote us just this week and said, thank you for the insight and detail you brought to each review session. I enjoyed the platform. And while it was more difficult than any other study tool I've used due to the pathophysiology emphasis, ooh, not coincidence, because I Pathophysiology is so important. It prepared me for the National Registry, passed it in 71 questions. Right? This is what we do. I'm not here to make you happy. I'm here to challenge you. The National Registry will challenge you. Your exam preparation should as well. All right, we're going to do 3 multiple response questions. We're going to choose 2 of the questions. Now, on these questions, when I took the Paramedic National Registry in January, I bet you 20+% were multiple response questions. We can choose 2 of 5 or 3 of 6. Now, following through with the pathophysiology concept, just type in the letters A, B, C, D, and E. You got to pick 2 of them. And you're going to get these on the National Registry regardless of what the level is. Miss Ragsdale, who recently passed a big exam herself, I believe. I'm sorry I didn't catch the name. Holy cow. All right. A narrow pulse pressure is most likely a sign of which of the following conditions. Select the 2 answer options that are correct. Now, these questions on the National Registry have no partial credit. You get them both right or you get the question wrong. All right? So basically, we know that a narrow pulse pressure is generally an indication of that compensation for shock. So that's what you should translate this question to in your head. A narrow pulse pressure is most likely a sign of which of these conditions? All right, the correct answers, so I can move this along a little bit. Choice B like boy and D like Dan Limmer. Tension pneumothorax, cardiac tamponade are going to cause obstructive shock, interestingly, for both of those. But that's where you're going to get the narrowed pulse pressure when it comes down to shock. All right, I'm going to pop the next question up here. Select the 2 answer options that are correct, 2 of 5. Which of the following statements should be made during the scene size-up? Now, what I like about this question, while it's not pathophysiology, the National Registry can take anything and make a multiple response question out of it. It doesn't have to be clinical. I think that's what's important about this, and I think it gives us a little bit of extra juice, a little bit of extra knowledge, right? The beginning of the book and the end of the book, some of this operation stuff you probably glossed over on the way to the gross pictures and soft tissue trauma, right? But you're going to get questions on this. And the way they ask questions don't look for memorization, they look for understanding. Now, what if you're taking this question, you say, well, what are the components of the scene size up? I like to say they're decisions, right? Okay, first, scene safe BSI, right? Number of patients, resources you need, and mechanism of injury and nature of illness. These are all done before you get to the patient, before you have contact with the patient, and that is another clue. Which one of these things would be done before you contact the patient? So the correct answers in this one. And you see how you can take a question like, scene size up question and make it challenging? This is why the National Registry is different than any exam you've probably taken, because they're going to challenge you. And that's what I want to do. The correct answers are choice B like boy. I'm not sure we can get this patient out of the car without extrication, right? That's a resource determination. And then C. The patient has their fist to their chest. It looks like chest pain. That's the nature of illness. Choice A, the pulse is rapid. All right, you're not touching the patient yet. You don't know. Let's move them to a backboard. You haven't made a priority determination yet. That's the primary assessment. And they're alert. We can take some time. No, those are all involving patient assessment. I don't care if you get this right by knowing the right answers or going through and thinking some are wrong. You can use the Sesame Street theory. 3 of these things are not like the other, right? Which ones do you do before you get to the patient? However you do it, that's okay. All right, one more. Which of the followings most likely indicates a 3-month-old patient who's been vomiting for 36 hours is dehydrated? Select 3 answer options that are correct. 3 answer options. 3 of 6. These would be just good to get you thinking. Got to put a PEDS question in. About 10% of the National Registry exam at all levels is pediatric right now. And remember, you got to pick 3. Now, when you're taking the National Registry, you have to pick 3. If you pick 2, they won't let you go on, and they won't let you pick 4. And you can always uncheck if you change your mind before you hit submit. So don't freak about it. Got a pretty good number of on-track answers here. As we're going to wind down a little bit here, but I just want to tell you, it's been so awesome to work with you all. And if you're watching this on YouTube and it's not live, I hope that you get a lot from this. That's really the plan. I'm going to put up the answers to this so we can go. We're getting a lot of pretty good answers here. And you know what? This is another one. I don't think you have to memorize vital signs, right? If you know physiology, right? If you know pathophysiology, that's why we do this. The correct answers are fewer wet diapers, right? Has the baby been wetting, fewer diapers? The diaper's been dry? A sunken fontanelle, right? 3 months old, this big anterior fontanelle is going to be a little sunken. An absence of tears indicates dehydration, because that's what most likely indicates a patient's dehydrated. A heart rate of 124 and a respiratory rate of 24 and a 3-month-old isn't bad. Baby crying? No, they can cry for a lot of reasons. They might cry just because we walked in the room. Fewer wet diapers, sunken fontanelle, and absence of tears. All right? So, wrapping this up a little bit, we got a lot of stuff for you. If you like these kind of things, you'll like what we do for this. We have review apps. You can screenshot these. Review apps are great all-around apps. Flashcards, review questions, National Registry prep for EMT, AEMT, and paramedic. Our pass apps, right? You want high-intensity questions. You like a challenge here. You want to be really challenged, maybe even a little frustrated, kind of like you'll feel at the National Registry. That's what the pass app is going to do. They're great apps. And EMTreview.com, if you want structured study plans, live review sessions with me, that's EMTreview.com, EMT and paramedic options there. You can also click on this link. Here's something free, just like this session was tonight. Pathophysiology-based assessment. Joe Mistovich is like a brother to me. We write competing textbooks. He's a best friend, and he's wicked smart, loves pathophysiology, a fellow nerd like I am. And this 2-part thing, if you're saying, gee, Dan, I really like this, I want to understand more, listen to this. It's going to be the best hour and a half you spent, absolutely free as far as you did this. All right, and that's it. It gets us to the end of this session. I'm going to sign off here. I'm going to turn my screen off and do these things. Thank you for sticking with me. You've been absolutely awesome in this. And this won't be our last Jeopardy. I'm looking forward to seeing you back again sometime soon.